Microphone is on.
Okay.
Both of you.
All right. So just to get started, I just want to let everybody know who I am, kind of what I do. So I'm the nurse manager for labor and delivery here in Joplin at Mercy. I've been doing labor and delivery about 20 years. So I don't know that I'm the best person to talk necessarily about all this, but I always have a lot of experience and a lot of been through a lot. So kind of the first things I want to talk about basically are just obviously your world is a lot different than ours, but just kind of what we look for and what, you know, as far as stabilizing our patients and what we're looking for when it comes to you bringing our patients to us. So obviously stabilizing mom, stabilizing her vital signs, ABCs, you know, prioritizing mom, IV fluids, oxygen, those types of things. Obviously, you have to focus on mom circulation, not even worrying about baby at that point in time, just because if we have no mom, we have no baby, obviously. So working on that. Anytime with any situation, whatever, we're going to talk about lots of different emergencies and lots of types of things, but any time you have a pregnant mom and you're bringing her in, always knowing that she needs to be laying on her left side. So we're basically what we're trying to do if there's a cord or if there's, you know, our heart tones are bad or our baby's bad or something's going on with that mom, taking the pressure off of the vena cava. So we always position our patients onto their left side. So just knowing that if a patient's coming in on a gurney, laying flat on their back, then, you know, not good. So whether you're just putting a blanket underneath them or whatever you're doing, because that's all we do sometimes, is just that, you know, hip roll, basically, just, you know, tucking them up a little bit just to get the pressure off. IV fluids and oxygen, always, never going to hurt anything, always supporting mom. And then monitoring vital signs, of course, and then bleeding, depending on if the patient's still pregnant, so antepartum, or whether the patient is delivered, obviously monitoring that, seeing kind of what we're looking at. So going into some specific emergencies, like one of the big one, and this is something that we just had a situation with the other day, and so it's kind of one of my top ones, is just a hemorrhage. We have lots of patients who plan to deliver at home these days. Some of them don't plan it, it just happens. A lot of them are planned home births and, you know, they go wrong, have hemorrhage, and, you know, those are kind of obviously the big thing. So in that case, if you get a patient that has delivered at home, planned or unplanned, and has a hemorrhage, obviously you're gonna, you know, get an IV, establish vital signs, like, you know, see where we're at. And the big thing with a delivered patient, and I don't know that this is something that you guys really know about or do, or maybe you do, I don't know, but the big thing with that is fundal massage. So I don't know, you know, how much of that you guys do know about or don't know about, but that's a huge thing with a delivered patient, is that they'll get picked up, get brought to us, and it's, you know, maybe an hour, and their fundus hasn't been rubbed. Back to that, a fundus is basically like their uterus. The top of their uterus, we call it their fundus. If they're delivered, the most important part, for 2 hours at least after delivery, we massage their fundus every 15 minutes. Very, very important. Clamps the uterus down. It's like it's having a contraction again. Rubbing it, it'll minimize bleeding. If you pick them up and for a whole hour they do not get their fundus massaged at all, the bleeding is just going to be like more and more and more. Now, of course, you're never going to do that on a pregnant patient, but always on a delivered patient. But that's very, very important. It's not hard. You basically go for the umbilicus. You're going to feel like a hard knot. I always say it's kind of like your fist. And then rub it, massage it, and then monitor bleeding. It's kind of hard because it's a lot of times we get like report and they'll say, you know, the patient's hemorrhaging or she's had significant blood loss, and it is a significant blood loss, but it's not always too much. It seems like it's too much because the average blood loss is 200 to 300 for a normal delivery. So when you pick them up and you see all this blood and everyone's thinking, oh, this is like tons of blood loss, It may just be normal. The biggest thing is, are they still bleeding? How much blood, when you massage their fundus, how much blood then are they having? Is their fundus hard and firm, like we would call it, and there's no blood at the time? Then you're good. All is good. Get some IV fluids going, they're good, all the things. But if their fundus feels boggy, which is basically like it's not going to feel like that hard knot like I told you about, or you can't find it, or anything like that, and they're continuously having bleeding, then you're in trouble. So the way to control that is to continue to monitor their fundus. Sometimes with someone who's it's hemorrhaging and has a lot of bleeding, you continuously monitor, you continuously rub their fundus. Rub it, see what the bleeding's like, rub it again, rub it. But if you rub it, wait 15 minutes and it's firm and good, then you're fine. So that's the big thing when it comes to hemorrhaging that we really see, is that we don't see that their fundus is getting rubbed. So it maybe has been an hour, and then we'll rub their fundus when they get there, and they have these big clots and stuff in there that have been sitting in there for an hour, and it's they're basically that's kind of the cause of that. That's kind of the reasoning for why probably they had so much bleeding. So those are kind of the big things, and then obviously on a hemorrhage, monitoring for shock. I mean, watching for that, knowing fundal massage. Those are the big things with that. Another one, this is obviously before they've delivered, but another big thing that we have a lot is our preeclamptic patients. So for example, if you go and the patient's complaining of a headache, they're 35 weeks pregnant, and they have blurred vision and this severe headache, and their pressure is like through the roof, obviously. They're probably preeclamptic. Those are big things. There's really not a lot as far as what you can do before getting them to us. The things we're going to do for them, of course, are labs and IV fluids. Obviously, we might start some MAG. Is that something you guys do? Do MAG? So if you have a patient like that, preeclamptic with high blood pressures, MAG, those types of things. A lot of times, big things, big signs, and some of this you guys may know. I'm not trying to say anybody doesn't know any of this, but they're pregnant, they have epigastric pain a lot of times, they're throwing up, they have blurred vision, they say they're seeing spots. Those are all big red flags. Oh, this patient's probably preeclamptic. So in those situations, treating their blood pressure, that would be the best thing to do. Some IV fluids, and then obviously get them to us. Start some MAG if that's something that you guys do, and then more than likely those type of patients are just going to get delivered. We're going to deliver them most likely ASAP, depending. But just knowing those symptoms that they have, the epigastric pain, the blurred vision, the seeing spots, those are all big classic, like, oh, this patient's probably preeclamptic. So just basically treating those symptoms, knowing, kind of recognizing those things. Questions on any of that? Okay. Anybody else have questions over that part? Okay.
You have a preeclamptic patient that's delivered, but it's
kind of the same thing. You just
you put MAG in there and you relax that.
No. Do you guys do Pitocin? No. Okay. So sometimes when it comes to that, do you do anything after delivery? Like, do you do Cytotec or Hemabate or Methogen or anything like that? TXA. Okay. So. Okay, so that would be something that you could do definitely, is if you do MAG. Now, just depending on the patient and what's going on, as long as if the patient's bleeding a lot and also is preeclamptic and their pressures are crazy and you think that you really need to start MAG, I'd go ahead and do TXA and just make sure that you're continuously massaging the fundus and making sure. Typically, if you're not going a long ways, you're going to be okay during that time. Now, she's already hemorrhaging and her pressures are high, probably just treat her pressure with whatever you guys use. We use Laetolol, but whatever you guys would use, because at that point she's delivered, you can use whatever you want just to treat her pressure until we can get her, so we can give her some PIT, because that's basically what we use. Anything to keep her from bleeding. Cytotec, PIT, TXA, whatever, we give it all to her. So typically mag's not the wrong choice unless she's hemorrhaging, and then I probably wouldn't use mag. So, yes.
I just have a question. So I know I've seen it and I felt it,
Mhm.
I've had children, but can you demonstrate a bundle massage?
Yeah, absolutely. So basically, like, you go to their umbilicus and you just kind of like see if you can feel it. Most patients, every patient's gonna be different. Some people obviously bigger than others, just kind of depends. But usually it's gonna be about 2 finger breadths below that. And then you're just gonna feel like right here. And most patients, it's obviously pretty, I mean, you're gonna be able to feel it, especially right after delivery. And it basically feels like a big hard knot. And you just like massage it as hard as you can. Sometimes you really have to like get in there, especially if it's a bigger patient. And you just, sometimes they grab your hand and sometimes they say, oh, that hurts, and you just massage it as best that you can. If it's firm, you're good. Now, if it's kind of where it feels like it's not that hard knot, like I told you, like you could feel it, but it kind of feels, we call it boggy, like, and they're continuously bleeding, then you need to massage it until it gets firm, and it will get firm. So you just keep massaging until it does get firm. Okay. What else? What questions about that? Before I move on to something else, I don't want to jump to something if you have a
The
question.
one I had.
The feta massage, yeah.
Terminology is clear, we hear it
Okay.
all the time, and the actual procedure is probably
Yeah.
a little fuller.
It's basically, yeah, it's in some patients it may be a little bit above, depending on how full their bladder is or how much bleeding they're actually having. If their uterus is really boggy, it may be a little bit above the umbilicus. It's usually very easy to find though. It's not something that you're going to be like, oh, I tried to find her uterus, but I couldn't find it. Typically, you're going to find it. And the big things with that is that sometimes you're like, okay, they have all this bleeding, there's blood everywhere. I don't know what's fresh and what's not. But if you massage and look and there's not this gigantic gush, then you're good. Like, it's good. You're fine. Like, because if you go to massage and it's just gushing. Now, sometimes you'll massage and you might get a clot or two or whatever, but as long as it's not continuously gushing, you're fine. Like, wait 15 minutes, rub it again. You're good. You don't have to continuously. But if you're feeling it and it's really boggy and you're continuously you look and you continuously see bleeding, you need to keep rubbing because that's what's going to fix it. Those simple things like that, and obviously if you don't have meds that you're using, because at that point, if we would rub their fundus and it was firm but she's still bleeding, then we're going to throw everything at her. We're going to start with TXA, give her some Cytotec rectally probably. We've already got PIT running on her. And then we're going to see what that does. And then if those things don't help, we're going to give her some Hemavate or Methogen or something like that. So that's kind of where we start. But the one thing that you can do, like where you're at, is going to be massage that fundus. That's the best thing that you can do. So, okay. All right. So, one of the other things I kind of wanted to talk about just a little bit before I get to just the actual delivery part. I know that's probably a scary one, just actually like doing a delivery. I know that's everyone's fear. But one of the things is like a uterine rupture. So if you were to get, it's hard to say because it's something that you're really not going to be able to determine if that's what's happening or not. But I just kind of wanted to go over it. It's very rare, but some things that would make you think, oh, this patient, I think she maybe has a ruptured uterus. So one of the main causes of a ruptured uterus would be someone who, let's say, has had a C-section and then is going to have a vaginal delivery or is planning to have a vaginal delivery. So we have protocols and stuff that we go by. So if someone were to have a vaginal delivery, then they had to have a C-section. Let's say they had a normal, uncomplicated vaginal delivery, and then their next baby was breech, and they had to have a C-section. They're a pretty good candidate for what we call a TOLAC, which is trial of labor after C-section. So that's a pretty good candidate for that. So we're going to allow those people to do that. But it's high risk because you cut into their uterus. So there's a good chance that their uterus could rupture. So, but we do it usually that one time. The people who are not good candidates for that are someone who's had more than one C-section. So if you get somewhere and what people are doing, where I'm going with this is what people are doing now is that if you've had more than one C-section, our physicians are not going to allow you to try to deliver vaginally. They're not. 1 is plenty, that it's already risky, they don't allow it. So people are trying to do it at home. So since we won't allow it, they're trying to like, oh, well, I've had 2 C-sections, I really want to try to vag deliver, so I'm gonna, use this lay midwife that, has no credentials, and I'm gonna try to deliver at home. But I've never done it before, but I've had 2 C-sections, so I'm really high risk. So one of the big things with that is you're not gonna know if you get there, they're trying to deliver, one of the big things is their history, like how were your other deliveries? You've had a C-section. Oh, great. You've had a C-section and now you're trying this home birth. So those are big things. They've had lots of bleeding. Another big thing with the uterine rupture is if they're just laboring, their contractions, their pain's going to be coming and going like contractions do. If they're ruptured, they're going to have constant pain, constant bleeding, constant pain, and have they had a C-section? Because most of the time, I'm not saying it never happens, but I would say 90% of the time, someone whose uterus has ruptured, they've had a C-section before. So if you get there and you see all this blood and this person's like continuously hurting and not, contraction, like, oh, okay, I'm good. Now I'm having a contraction. Okay, I'm good. Off and on. But it's constant pain and they're bleeding, and you start talking to them about their history and they say, oh, I've had a C-section before. It's a pretty good chance it could be ruptured. You don't know that, but it's a very good chance. So for us though, that's a great thing for you to tell us on your way, so we're prepared for that, because that's a huge disaster. We're probably not going to save that baby. We're probably not going to, we'll save the mom, but we're not saving her uterus. So she's going to get a hysterectomy. So those are great things for us to know ahead of time. Like, hey, just so you know, she's had a section before. She's laboring at home. Good chance she, for us, the things that we look at. So if I'm laboring a patient and I know that she's had a C-section before, and obviously I lose heart tones. Those are the first things. I know you guys don't do that in the field, but that's one of my main things that happens to me is I lose heart tones. The second thing is when I do a vag exam on the patient, let's say she's laboring, I check her, she's 6 centimeters. The next time I go to check her, she's hurting, I lose heart tones, I go to check her, no presenting heart. Well, why? Well, because her uterus just ruptured and now her baby's floating around in her abdomen. So there's no way. So those are the things how we distinguish that. But for you guys, the main thing is their history. Like, okay, you're having this home birth. Is this your, or maybe they didn't mean to. I mean, sometimes they don't mean to. But you're having this home birth, so now, but what's your history? Oh, you've had a section. Oh, great. Okay, now you're bleeding and you're having constant pain, and and they may not be having one or all of those symptoms, but those are all really good things to know about. So then for us to know, hey, probably some blood, a his set, like this is what we're looking at, probably where we're going with this, just so we're prepared for some of those things. So that's kind of the big one. Very rare, but it does happen. I've seen it in my career a couple different times, unfortunately. It's usually not a good outcome. But just some things for you guys to be aware of as far as like some questions to ask and history and things like that. So I guess delivery, we'll talk about that a little bit. So if you get somewhere, obviously, and the patient's delivering, I mean, obviously 99% of the time, if it's coming, it's coming. Like if it's coming out, then you're gonna deliver it. The big things for that are obviously the supplies and the things that you have or need. I don't know what all you guys have, but bulb suction is the main thing. Another thing that I see a lot of is, well, let me go back a little bit and then I'll talk about that. So the big things are guiding the head. The one thing that we don't want is for the baby just to like shoot out, basically. That's not a great term for it, basically, but just because then you're going to have more tearing and things like that. So you just have to guide the perineum, hold the head, basically, so that you have a more controlled delivery versus if it's coming, and a lot of times they just kind of like shoot out, and the mom has this big tear, and that she's bleeding from that, and like all the things. So those are the big things. They're just, if she says it's coming, if the baby's crowning, just hold onto the head, just guide it out, suction the mouth and nose, dry and stimulate. And then the one big thing that I see when we have patients that come in from being delivered at home is the best thing you can do for the mom and for the baby is put the baby skin to skin. So we always see baby wrapped up in blankets, mom on the gurney, and them coming in like separately, like, you know, coming in separately. The best thing you can do is put that slimy wet baby up on mom's chest, down in her shirt, in her whatever she has on, skin to skin with mom. That's the best thing for her, the best thing for the baby. Okay? So that's something we don't see typically. In some cases you can't. We had a patient the other day that, you know, the patient was refusing everything. She didn't want an IV. She didn't want anything. She couldn't have held her baby. So I get it. But especially when you're not even sure like how many weeks this baby is. So is it a little preterm? Is it going to have a little bit of breathing issues? If it is, you know, if you're talking about you have a 35 or 36 weeker, that's what we're going to do when we get it is put it skin to skin with mom. That's what's best for it. That's what's best for its lungs. That's what's best. Make it cry, dry and stimulate it. Like that's what's going to be the best thing for them. So that's something that we don't hardly see. And I know that a lot of it is just because you guys think, oh, warmth, like we want to keep the baby warm and, you know, all of the things. But the best thing for it is to put it on mom's chest. Questions about that? You guys normally do that? Have you heard of that before?
Definitely heard of it, yeah.
All right. So let's see. Oh, and then like as far as delivery goes, the placenta, a lot of times people are like, oh, I didn't know what to do about the placenta. You know, sometimes it can take up to 60 minutes for the placenta to deliver. So you don't have to worry about it, basically. If you feel like the patient's bleeding, let's say the patient delivers, you know, you're on your way and you feel like the patient's bleeding a lot, sometimes until the placenta comes out, it's going to seem like they're bleeding a lot. So you can, like, if it's like setting in the vaginal vault, sometimes you can just like pull it and it'll come on out. You don't want to tug on it and, you know, get some of it and not get all of it. But if it's just setting there, you can pull it out. But otherwise, if her bleeding's okay, which a lot of times until the placenta comes out, it is. So just leave it. You don't have to do anything with it. You don't have to worry about it. Just leave it. We'll deal with it when she gets there. So those are the big things. Just, you know, once you cut and clamp it and, you know, put the baby up on mom's chest, leave it, and we'll deal with it when they get here. Questions about that? Okay. All right. So let me make sure. We talked a lot. Falls and trauma. That was one thing that was kind of on the list of some topics. As far as for you guys, I mean, we're kind of back to just the ABCs. Taking care of mom. If she's had a fall, I mean, knowing her history. Has she feeling baby move? Is she not? You know, those kind of things, like just kind of going over, like, obviously we have to treat mom for all of, you know, any complications if she was in a wreck or anything like that. Do you guys have a Doppler? Do you do heart tones at all? Okay, I didn't think so. So those are kind of big things because for us, you know, obviously we want you to take care of mom, and then we're gonna, once they're in the ED, if it's a, you know, a major trauma or some sort of thing like that, we're gonna Doppler heart tones. But other than that, we have to take care of her first. So as far as from our standpoint, same thing, off the vena cava, up on their left side, that kind of thing. Just go with it. I mean, there's nothing really you can do until we get there and get heart tones and things like that. So there's nothing that you're going to change as far as, you know, if you think she's unstable, obviously the whole oxygen, IV fluid, all of those things. But as far as from the baby perspective, there's nothing you really should do differently. What else? What did I not talk about that you want to know about? Or questions that you have about anything that I talked about? None?
We're catching up
There's
right now.
there's a little bit of a delay.
Okay, perfect. I'll make sure I went over everything.
I guess my only question would be for uterine rupture,
Mhm.
what would we be able to do? Like as a paramedic?
So really, I mean, as far as the baby goes, nothing. The mom, basically fluids, you know, things like that. Get her here as fast as possible. It's not going to be a good outcome. Whatever happens, the fast as you can get here. Obviously, IV, make sure the mom has an IV, maybe two, honestly, 'cause she's gonna get blood. So two large bore IVs would be great, and a lot of IV fluid, some oxygen, and that's really it. As far as saving the baby, you're not gonna really do anything. If she's that far away, I mean, we're gonna be lucky if she's in the hospital for us to save the baby, if that happens. So for you to save it, I think, like I said, the big things are gonna be for us saving mom, just being aware of that. Oh, she's trying to vaginal deliver at home and she's had a C-section. And I don't know, maybe that's something that's like, you guys are like, oh yeah, we're on that. We know that. But just knowing that, like, recognizing that as far as like, okay, huge risk, huge risk. It's a huge risk for us being, 5 minutes from being able to get the baby out. So for her to be, at home and that happened, it's not going to be a good outcome. So for just recognizing the symptoms of that, so we're aware of it. Like, okay, she has constant pain, she has increased bleeding, she's had a previous C-section, like she's tried to deliver at home. So just recognizing those things so that we can be, because otherwise it's going to take us a little bit of time once she gets there for us to like go through her history and get everything and figure it out. Obviously, we would get heart tones right away, and if we don't have heart tones, then that's a huge concern for us. We would check her right away, and if we end up with no presenting heart, but in that case, we hadn't checked her before, so we didn't know if there even was a presenting heart to start with. But so if we have them in the hospital, that's a big thing for us. Is that I just checked her 30 minutes ago, and she was 6 centimeters and low, and and then I check her again, and I have no presenting part. I can't feel anything. It's obviously because it's not in her uterus anymore. It's floating around in her abdomen. So as far as baby goes, if you're out in the field and that's happening, no, there's not a lot that you're going to be able to do. Just treat mom.
Is this where you guys come off of the OB floor and come down to the ER and meet us? Because we have Pulsera now, we can communicate all of that stuff to Pulsera, and
Right.
those ER doctors or nurses to call you guys.
So I think it's an awesome thing for us to come down and meet you, just to get you where you're going in the right place. We're still going to come to OB for that, because she's going to have to go to her section.
Okay.
And that's where I'm going to do that at. One of the big things for us to meet you in the ED is going to be those deliveries that, like, you're having a delivery happening,
Right.
and maybe we stop there first, just because it can be a little bit more controlled. I'd rather deliver a baby down in the ER than I would in the elevator.
Right.
So just, so those types of things. So if you think it's happening or it's already happened, then so be it. Just, bring them on up. We'll take care of it all there. But those patients who, especially if we have a possible preterm baby, and I don't want to deliver that baby in the elevator and not have, the correct supplies and stuff. I'd rather stop down there and have everybody meet us there, and then us stabilize them. And once we feel comfortable, then transport them up. But anytime you feel like, oh, I don't know that we're going to make it up to labor and delivery, or I think I want someone from labor and delivery to come meet us outside, and we're happy to. Just give us a heads up. We'll come meet you outside. You can give me the scoop on the way. That way, by the time we hit the floor, we can hit the ground running. Because a lot of times those type of patients, we might go straight to the OR.
Right.
If I already think, if you've been talking to me for 10 minutes and you tell me we think that we're having a uterine rupture, then there's a good chance we could go straight to the OR, because at that point, we're just not talking about delivering the baby. We're talking about the baby's probably already gone, and we're trying to save the mom at this point. So time is very precious to us. So yes, me meeting you down there in the extra 4 minutes that I get to talk to you on the way up and evaluate the situation, it's key. That's a very key point. So anytime you feel like, or for you guys, I don't want to ride this elevator up with this patient by myself. I know there's somebody that, always call us. We're more than happy to come down, meet you down there, and come up with you, or decide, should we go up, should we stay here? Because it's all, you never know what's going to happen. But it's, if I get down there and I see the situation, and then I may say, no, I'm comfortable, let's go. Like, come on, let's go ahead and go up. Then we can go up. But for you guys to just, sometimes we don't even know that you're here yet. You know what I mean?
Right.
We're still like, we're doing other things. We don't really know. We don't, we get a lot of our information from the ER, they tell
Right.
us. And so, no offense to them, but, they don't always know the correct questions to ask, so for me, I have 4 other questions I wanna talk to you and ask you about,
Right.
So those are always
Well,
good things.
Sarah's nice because it gives us an estimated time of arrival to the hospital, and from what I've found, it's pretty close.
Good.
So,
Perfect. Yeah, so anytime, and anytime you can always ask them, or anybody you're talking to or whatever, like, you want to talk to a charge nurse. I mean, if it's a serious situation that you think like, okay, this is not good, don't hesitate to say, I want to talk to the charge nurse up there, where we're going, I mean, anything like that. If you want to, give us a heads up of, I'm not sure what we're dealing with here. Like,
Right.
this is what's going on. These are some things I'm concerned about. Just so we get a heads up, because we never know what we're getting. Sometimes we get patients that come in that they think they're in labor, they're having a baby, and we send them home 30 minutes later. Like, I mean, you never know. And then sometimes it's like terrible, like it's an awful, tragic situation, and things like that happen. And so we just never know. And I'm not saying, oh, we take it lightly. Oh, we got an ambulance patient coming on. Like, it's no big deal. But sometimes, like I said, sometimes the patient thinks they're in labor and they go home in 30 minutes because they're closed and they're not having a baby. So, we just don't know really what we're doing right. So if you're, you have somebody that you're like, I really want to talk to whoever's in charge or a nurse about this situation, and, let them know, like, hey, this is bad. This is, can you meet me downstairs? So, what was your question?
So you said, you and ruptures are pretty rare. With more and more home births happening, are you expecting to see an increase, or have you seen an increase?
I don't know that we've necessarily seen an increase. I would say we've seen an increase in a lot of like lay midwives, and a lot of like where they will agree to labor these patients at home. I don't know that it's increased yet, but yes, I can definitely see it. A lot of patients, with social media and TikTok and all the things, they don't want to listen to what their provider has to say, that they saw it on TikTok, so it's okay to, try to vag deliver at home after you've had 2 C-sections because somebody on TikTok did it, so they think it's okay. So yes, I think with social media and I think with all of those things, yeah, we try to, our providers, ourselves, we get patients in triage all the time, and they are adamant that they're not having a C-section, and that they're going to try to deliver their baby at home, and then they'll just refuse to come in, and then it's bad. So yeah, I do think that it is going to happen. I think that it hasn't happened yet, but I do think it's going to happen more and more.
Labor parties around here that usually been.
I don't know them personally, but we've had some situations, yes, that they have done it.
There's several around town that do it. We ran into a couple of them where mom and baby were good.
Not good, yeah.
And at what point do you guys like that?
We went straight to OB on those patients. She'd already delivered baby at home. Mom and baby were both not good, and went straight to OB.
And typically, that's the ER is going to want you to do that. I mean, even if the patient's kind of unstable, if they've delivered, they're going to want you to come to us, because we're going to be the ones to fix that, even if we're doing a hist on them or anything like that, because obviously if the patient's having a chest pain or something like that, obviously we want it down there. We want them to stop down there. But if it's something to do with their delivery or hemorrhaging or something like that, they're going to want you to come straight to us. So yes. Another thing that I just briefly want to touch on, just because I know you guys don't do vag exams, so I know that this necessarily isn't going to be something that you're going to even know is happening. But I know that I've had a patient before that has called or came in by EMS, and they've said, oh, the cord's hanging out, basically. Like, I felt something, the cord's hanging out, which is basically a cord prolapse, which is not good. It's a stat C-section. That's what we do when that happens. So in those situations, I just kind of wanted to talk about that a little bit, because it is like, obviously it's a big deal. And so just for what for you to do, basically, in that situation. Same thing, like I said, turn the patient on their left side. I know you're not going to have heart tones, so you're not going to know if if there's heart tones or if there's not. One thing that you can do, I don't know if this is something you do or don't do, but this is what we do. I'm just telling you. What we do is, so one thing that can save the baby's life, a lot of times if the cord is hanging out and the head is, so let's say this is the cord and the head is on top of it, smashing the cord, cutting off circulation from the baby. So what we do is we do a vag exam and push the baby's head off of the cord. So in an emergent situation, if that's something that, I don't know that anyone will do that or is comfortable with that, but if you know that there's a cord prolapse or you see a cord hanging out, because I've seen them hang all the way out where you can see them by just visually looking and not having to feel. So if you know that that's happening and you see that, that's something that you can do, because if you let that head rest on the cord the entire time here, the baby won't make it. So that's just a whole nother, like, you know, thing. If I go check a patient and I feel a cord, what we do is I keep my hand in the entire time, hold the baby's head off of the cord, ride my little self right on back to the OR, and they do a C-section while I'm holding the head off of the cord. Because if I let go and let the head back down and smash down onto that cord, it's gonna cut off the circulation and we're not gonna, the baby's not gonna be good. So I'm not saying that, I know that you don't do vag exams and I know that that's not something, but if you know that there's a cord, that's definitely something that you could do to try to save the baby if that is.
That's in your training.
Yeah, if it's
That's
something
the only
that
time,
you,
basically.
I mean, it's definitely not something I know that everyone's gonna be comfortable with, but if you know that that's what's going on and that the, you know, it's gonna save the baby's life, and basically all you have to do is put 2 fingers and push, you're gonna be able to feel the hard head and push it up above the cord, just so that the cord can get circulation. What about questions about that?
Questions online? Oh, thank you.
So that's good.
Anything I didn't talk about? I know hemorrhaging is a big thing.
Yeah.
So breech delivery, there's not a lot as far as just, like I said, if it's gonna come, it's gonna come. If it's breech, it's coming. The only thing you can really do is do your best at, obviously at the end when you're getting the head out, you just have to,
Hopefully, face down, I guess.
Yeah.
So hopefully the presenting part is the posterior
Yeah.
part.
so definitely, so if you're delivering and let's say your baby's coming out like head up, like so sunny side up, and you get to the head, and let's say the whole body's out, you get to the head and it's looking up like this. The best thing that you can do is try to rotate it to pull it out the other way. That's gonna be the easiest part. But if it's coming out the other way, it's probably gonna go ahead and come out. It's more than likely you're gonna be able to like kind of get your fingers in, kind of close to its ears and kind of guide it out. But if it's facing up, so if it's looking up at you, like sunny side up, the best thing for you is gonna be to do your best to kind of rotate it to make it come out the other way, because it's a lot smoother path that way. So that would be the only thing.
You wanna rotate the body.
Right, the whole body.
Well,
The whole body of the baby, mostly the shoulders, neck, head. Like you're gonna only basically have about this much of it to where you're gonna be able to move, but to hold the body and then twist the neck around to where you could have it come out. And then, yeah, basically, I mean that's really what you're. Another thing that can happen, which this is something that also like it's kind of one of those things. Typically, if they're gonna deliver, it doesn't normally happen, but a shoulder dystocia. And that's kind of a big one too. The one thing that you can do, usually same thing, you're able to kind of get your fingers in on that anterior shoulder and kind of pull it down, and then it'll come out. Another thing that you can do is you can do like suprapubic pressure, which is going to be kind of like right here. You want to make sure the mom's completely flat, legs pulled as far up as you can get them, and then have someone do suprapubic pressure, which is just basically like right here, and push, and you can almost kind of feel where the shoulder, where the baby needs to come through, and just have them push. I mean, we sometimes like get up on top of the mom and push. So just if the baby's stuck like that, then just, yeah, get up, push as hard as you can. like I said, typically something like that, if they're gonna deliver, normally that doesn't happen. A lot of times what happens with those patients, it's someone who's labored for a really long time, has a big baby and things like that. So you're not gonna see that a lot with someone who just, whoops, I delivered at home, or whoops, I, had a, maybe in a home birth necessarily, they would have, but typically if they had a home birth and had a midwife, they know what to do on a shoulder typically. So, but those are big things. Head flat, legs up, grab that anterior shoulder to try to like pull it out, and then that suprapubic pressure. Those are the big things. What else? What questions? Okay. I think that's all I have.
We appreciate you coming in.
Absolutely.
Yeah.
All right. Thank you guys.